So I've probably got a slightly different title than Paul originally introduced. We talked a little bit back and forth and settled more on a focus on connective tissue injuries within the hamstring group, which is effectively the intramuscular tendon. We'll look more at the similarities and differences through this and how that might affect our management. So I might just start with this. I don't have any conflict of interests that I think will affect this presentation. And also there are two learning objectives that we've provided for you today. The first one is to get a look across, and this is certainly not exhaustive, but looking at the current literature with respect to structural and functional properties of the intramuscular tendons, more so around the hamstrings, but more generally, and also how injuries in this that involve these particular structures might affect our management, but also probably develop some appreciation also of the knowledge gaps. So what I'll be doing effectively is I want to provide a little context of things that have gone before this presentation and some great work by so many people in this area, and then focus more on what we understand to date, on what we what can be termed either an aponeurosis, intramuscular connective tissue, or intramuscular tendon. I'll probably flip a little between the three, but I'll try and keep to one, which may well be the intramuscular tendon, more for simplicity, but please appreciate that these aponeurotic structures are not always or exclusively intramuscular. We'll have some overview of the radiology and common presentations, and then really discuss out of that and some other background material on pathology, how we might best approach the various phases of rehabilitation. So contextually, it's really only 10 or 12 years ago that there was this increased awareness of intramuscular tendon injuries, and the initial work by Jules Common and others was, is there a longer return to play with these injuries? And his original work found in a very small series that perhaps there was, but then of course there was a very good rebuttal from Anu van der Meijde and your colleagues at Aspetar, and I think this set up a really good framework where we can't take all of these things on face value, and we should look more deeply and more prudently at how we view our initial understanding of things. Of course, Noel Pollock's great work with the British Athletics Group, and first in developing a radiological grading system that specifically defined whether there are intramuscular tendon injuries involved or not, and if so, what severity. And they found, looking in a 4-year series, that of the 2C injuries, 57% occurrence, and of the 3Cs, 62% of their hamstring injuries, and did recur, which is a real concern to them. More recent work, there's been a paper from the Isern Kebschel, Carlos Pedret group with a couple of factors that probably predict poor outcome, and we might get to those a little later. And also a very fine review by Fergal Kieran, looking a narrative review of the intramuscular tendon, and within that, the fact that clinical tests probably cannot exclude with reliability discriminate whether we have an intramuscular tendon injury or not. The British Athletics Group went back and over a period of the next a couple of years rehabilitated their intramuscular tendon injuries in a different fashion, being far more careful early, and then some other specific work as well, and found a significant reduction of recurrences, such that they only had 3% across the entire cohort in this following study. The return to play period was pretty similar. And then, of course, we've got the large blinded studies, well known to us, the Netherlands Aspetar connection, and out of that, a subgroup, again by Anne van der Meijde, showed a similar return to play between those with and those without intramuscular tendon injuries, but also those that did return, that there was incomplete healing. And I'll touch on this a little more later, but this showed that that people could survive, certainly 80+% of them could survive with incomplete healing of these lesions. Of course, then there was some further debate about whether the different cohorts might have had something to do with the differences in outcomes or recommendations, and certainly the thought that perhaps elite athletics is less forgiving than perhaps some of the other sports. But again, more debate, healthy debate, and this all contributed to the growth of knowledge in this area. And I commend all the great contributions with where we are. So this raised the question, which was the one Rod initially put to me, and Anders was slightly different. So I was trying to work out exactly where I'm going to play this, but effectively being asked, well, how might the presence of intramuscular tendon involvement alter our early management of lesions? So to start off with, we need to appreciate these structures in the anatomy of the hamstring. So this is a great anatomical slide, again from Jaime Isen-Kebschel. And we see here the common tendon of origin of both biceps and semitendinosus. Semitendinosus is often muscular from its origin, but of course it has this joint origin also from the common tendon. Biceps, of course, this common tendon actually tracks distally and then actually becomes intramuscular as it courses down the biceps itself. And of course, fibers from that then insert into its insertion here. So I've got this tendon of insertion, tendon of origin, and similarly with semitendinosus, we've got a tendon of origin and insertion. I'm hoping you can see over here that work from Arne van der Meijde in his very fine 215 description of the anatomy of the hamstring origins and insertions, and the actual lengths of these aponeurotic origins and insertions that we need when we're talking so much about today. So of course, semitendinosus has the intramuscular raphe, which extends the whole length of it, and which is in fact a lot more compliant than the other the aponeurotic contributions that we'll be talking about today. Zipper lesions, or we may not get to talk too much about today. If we do in question time, I'm happy to go there. And lastly, semimembranosus, which has the largest cross-sectional area, largest muscle volume, quite a long tendon, a membranous tendon of origin, progressing to an intramuscular tendon, and then the tendon of insertion, as you see there. Now we need to understand a couple of quite unique properties to this intramuscular connective tissue. Effectively, it's formed by the perimysium of all these muscle fibrils and collection of muscle fibrils, and this is interwoven to actually form these intramuscular tendons. It's collagenous type 1 and 3 with some type 5 collagen as well, and the proteoglands glycans are actually different to that of free tendon. So rather than free tendon where we see this interfascicular gliding and we get strains of up to 6-8% or so, that the intramuscular tendons or aponeuroses are much stiffer than that, particularly when the muscle's activated, and more on that later. The stiffness of the endomysium is quite compliant, epimysium is quite stiff, perimysium stiffness lies somewhere in between. Some very good work's been done over the years in showing that chronic strength type stimuli lead to adaptive stiffening over periods of 3 months plus, both for Kubo and also Wakahara looking at vastus lateralis. Short-term rest of these structures, in fact only about 20 days or so, leads to decrease in stiffness, and Järvinen found something similar too. The other concerning factor with the interrelationship between the contractile element or fascicular element and the this connective tissue element is that fascicle length changes, as we've seen from Tony Shields' group, Dave Opar, Ryan Timmins, is that we can see fascicle length change quite dynamically, whereas the intramuscular tendon adaptation may well lag these changes. This was described by Purslow, who spent his life studying these aponeurotic structures. We also need to be aware, I won't talk any more of this, of the intermuscular connective tissue, which between synergists, which are able to distribute some of the stress or tension from one muscle across to the next, but we won't cover that today. In terms of understanding the behavior of this activated muscle aponeurosis element within the myotendinous unit, we need to understand that when a muscle contracts and shortens, that the muscle actually broadens. And those of you who've got access to ultrasound will see this. And but of course, the aponeurosis can't slip and slide away, so it effectively shapeshifts, and it becomes shorter and broader as well as its collagen, interwoven collagen, actually changes its shape. And this is quite a unique feature of this biaxial property. And we do know that when we activate the muscle to 40% of MVC, which is not all that much, but then the soleus aponeurosis stiffness becomes twice that of Achilles, and then it becomes even stiffer with higher degrees of muscle activation. And so it's this dependence on degree of muscle activation, which is a feature that probably hasn't been understood until more recently. The other thing to understand is where we have segmental or functional units within a muscle, say in soleus or in biceps or others, that we might see asynchronous firing of these particular functional units within the muscle. They'll drag on the aponeurosis in different ways, such that, and a lot of this stress then needs to be absorbed within this interwoven matrix that forms the aponeurosis as well. So something we'll probably come back to a little later. I broached this particular feature in that that the aponeurosis strain and stiffness is dependent both of the starting length of the muscle and also the degree of activation. So if we look at a starting length, as you see here, and this is from Miyamoto's work, which is pretty much the late swing phase of running, that if we put a muscle at or fix it at that length and then perform an isometric contraction at intensities of anywhere between 10 and 70%, we get a most lengthening of the distal part of out around 9% or so at higher demands, and less, in fact, less lengthening to only about 4 or 5% of the proximal aponeurosis at higher strains as well. However, if we then put a person in a shortened position, and I had to flop between different articles to find this, is that in Kellis's work, where he had a person in prone at 0, 45 and 90 degrees, that as that proximal aponeurosis, if we do an MVC between 20 and 60%, let's say 60%, that the aponeurosis, because it's broadened as it shortens, that in fact we get this shortening of the aponeurosis of around 6%. So depending on your starting length and your degree of activation, we see this very broad, very wide change in features or shape shifting of the aponeurosis accordingly. And this just highlights what I've described to you before. There's also, if we look across any aponeurosis, there's significant variability, both in its thickness and thence the stiffness and strain properties. So here's another feature that certainly changed my world somewhat, and this headline, if you like, was from Tecchio's article this year, and many of you may well have read this, but yeah, to which he led with, well, if we perform an eccentric of the muscle tendon unit, that the fascicles are not eccentric. This also depends obviously on activation as well, but in higher activations, that in fact the muscle fascicles stay largely isometric, with both isometric and eccentric contractions. And this isometric is held at shorter lengths as we go to higher intensities. So if we look at a person, and this is their work, performing a Nordic activity as they lower further towards the ground, we can look at the muscle tendon unit change in red here, and this goes from to lengthening out to around 5 centimeters or so. If we look at the fascicle length changes as soon as they start doing their isometrics and hold through here, that in fact it shortens by about 1 centimeter or so and holds this through pretty much the entire Nordic until just near terminal phase, as one relaxes to hit the board, that the muscles relaxed, it then lengthens, and this is where the only lengthening that occurs in the fascicles. The EMGs reflect this. Of course, it's the intramuscular tendon aponeurosis, call it what you may, that has to accommodate the balance between here and here, so it of course lengthens. I'm sorry. So they term this a shortened stretch action, as you see here, as opposed to a stretch shortening action. So it's not about fascicle shortening and lengthening. The fascicle shortens and holds, and the lengthening occurs in the intramuscular tendon or aponeurosis, hence the increased stress and strain on that area. We also know that pretty much the same happens if we look at more functional activities like running in both the hamstring and calf muscles, that in both these muscles now, over about 6 meters a second, we see the actual fascicle shorten with increased speed. They act quasi-isometrically, again, shorter lengths at higher speeds, and the aponeurosis effectively undergo pretty much the length changes that we see in the hamstring muscles as we get out to running at faster speeds. So they increase in both length and stiffness. So our question then is, well, when we perform eccentrics, what happens? What happens when you do an RDL? And it seems that in fact, for us to be doing this paying out sort of activity, that in fact what we do is fire less motor units. We see very low EMGs, both in a pilot study we did, but also Dave Opar and his group have seen a lot of this too in doing RDLs. So these are not high intensity exercise, and it's this paying out of these motor units which enable us to lower our body plus or minus the weight to the ground. I'm going to change tack now and look at MRI grading systems. And of course, we had a number of these in the early in the last decade, I can say, and early in the last decade. But since then, from Pollock's study, the Prakash looking only at calves, the Valet and Isern Kebshel, they're the same group, I believe. All of these now have identified different methods of grading the intramuscular tendon injuries and relating them, which assist very much in how we might look at its involvement and how that might affect our management. There's some great reviews, again, by the home team, by Wangerstein and etc., as well as Bruce Hamilton, who we know well, and Tom Best there. So the commonly affected structures, the one we hear most of is affectation of the common tendon, as you see here. And again, this was Paul Galano's wonderful dissections, both here and here in Annie Vandermeid's article. But the common tendon here is quite a common site for a poneurotic or intramuscular tendon injury, as well as the raphe between the semitendinosus and biceps, and certainly down around distal biceps tendon, the distal run out of the common tendon as it becomes intramuscular, and you'll see that very fine intramuscular tendon in this axial view of the long-headed biceps there. We can also see intramuscular tendon injuries, either of the free aponeurosis of semimembranosus, or also down in to the intramuscular portion of the terminal filament of the semimembranosus tendon as well. And of course, that is it here. So these structures. I've also made note of the T-junction injuries, but I don't quite think we'll get to that today. This is, I'm very grateful that the sharing of this by Professor Shoulders, just of these illustrations, that it's worth knowing some of these, a very small percentage do get to require surgery, and the more problematic ones for us are those involving the common tendon of origin, where we've got an avulsion distally of the long-headed biceps, and you can see where it's avulsed down here. And I've only seen one or two of these personally, but to see a person struggle on for the rest of quite a long athletic career with ongoing hamstring injuries because this wasn't picked up early and wasn't dealt with as we probably would today was very difficult. So many of these will heal well conservatively, but at high-level athletics, there is the consideration for the type of repairs, either for some of these splits, but certainly the common tendon repairs too. Peter Bruckner mentioned that in his early article. Now, from Fergal Kieran's work as well as others, it seems there is no unique mechanism of these intramuscular tendon presentations. The most common story, certainly in my experience and talking to others in the football codes in particular, but also in athletics, is this superimposed stretch on a very high force, high length, high force, optimum length sort of condition of the intramuscular tendon. So a person sprinting along in a 400-meter run and then hits the bend, there's an increased length demand on the outside leg. That's the one that's almost exclusively torn in 400-meter runners, and that's one such example. The other one is the overstretch or the sudden increase in trunk flexion in any of the football games, this sort of thing. So this is the common presentation here. Less common ones are the bending down to pick up a ground ball. Now, is this about poor eccentric control rather than necessarily an overload of the intramuscular tendon. What is it due to local fatigue? The last one we only really see in, again, my athletics interest here is people running PBs and that have maximal efforts that might increase their personal best by a couple of tenths of a second, and then front up maybe 2 or 3 days later to then tear their hamstrings. And it's as though there's of course, after any overload, there's a remodeling period after that, and perhaps it's in the catabolic period of that remodeling that these things let go. Fergal, in his series, in his review, really found that there were no universal or unique clinical signs that could discern with an intramuscular tendon injury. And I think it comes very much more down to site, severity, and the failure to progress. I think are the main things. And our challenge then is how much protection really to provide in the early stages, our trajectory of reloading, and how it might change our actual management. It is very much about the when and how in our early and late stages, and then how we might go through the rest of our rehabilitation. The healing process, I'll spend very little time on this, and all of us group, I think in our undergraduate years, learnt so much from the Yarvinen group on the progress of our early myotendinous lesions. What has made less of the headlines is attached to that group is Karainen's work, where if we do get, and I've actually modified this to what may occur in intramuscular tendon injury, where we have our lesion, we of course this becomes unstable, but then in either myotendinous unit injuries or myoponeurotic injuries or intramuscular tendon injuries, that there's a change in the shearing that goes on between all of these myofibrils. So the body lays down integrins and through this area to effectively splint the area, so that from day 5 onwards, such that we're getting less movement at the site of injury. It pretty much splints that site of injury for the next couple of weeks until there's the formation of either some form of healing across here and the new myotendinous units. We do know that it thrives on a mobilization to continue this, and that immobilization actually inhibits the process. So it may well be applicable, but we don't know that. I wrote to Tero Yarvinen, but have not yet had a reply to that. Some great insights from Vermeulen's paper, which you know well, so I hate quoting back to the experts, but I really do admire this paper. It gave us great insight into the possible time period we're dealing with. But at baseline of 34 partial tears that at their MRI, having passed all the metrics to return to play, so mean 31 days, that 18 of 34 partial intramuscular tears have become continuous. Of the complete tears at baseline, 6 of 7 had partial regrowth. So we've got sort of immature scar here as well. That tension had redeveloped in the waviness, 61% at baseline back to 12%, and we see this classical thickening of this immature scar as it's undergoing the remodeling period. So we know that occurs at 31 days, or a mean of 31 days. To couple with that, this excellent paper this year by Hami Esen Kebshel, and he was very gracious in allowing us to share this here with you today. So what they've done effectively is then taken the Yarvinen work, and in fact Tero Yarvinen was involved in the paper, as well as their MRI findings, and have been able to look at the particular features of MRI, so we can then determine the degree of healing And so in the first phase, the destruction phase, that we've got basically just increased T2 signal. There's a small halo, so these lesions actually heal from the outside in because there's better blood supply externally than internally to this scar. And then from there, this becomes early scar formation here, more mature scar formation, maturing scar formation here. Out around 8 weeks, it's relatively mature. In 16 weeks, it's pretty much healed. Now, there's a huge range, and I urge you all to read this paper. The range within that we see, depending on the site of the injury and others, is something to behold too. So that don't take these numbers. But these are more typically, or to provide a typification of this sort of progress. How might this affect our rehabilitation? The question at large. So it's pretty much about longer protection in the early phases. And here, of course, is an importance on relying on the present active cytokines and M1s and M2 macrophages. M2 macrophages are very important to us because they, in this case more than anything, in that M2 macrophages, which are the anti-inflammatory macrophages as opposed to the pro-inflammatory, are importantly involved with formation of fibrosis and connective tissue healing. So how might this affect us? So that we need more and longer initial protection, that we can't rely on symptoms, that sometimes our imaging will help us with knowing exactly where we are in this particular case, and for the more severe cases, quite significant unloading. If we talk to Tom Best, I'm sure he'd tell us that use of compression or cyclocompression could be something to consider in this phase. And certainly muscle activation of itself produces some activation in which we'd undertake certainly in latter phases. And we do know from Yarvinen's early work that we want to begin muscle activation certainly by day 7 out to day 10. We do need to be aware of significant cross-sectional area losses and to get a surgical opinion if it's required. So as we move into sort of stage 2A, so I've tried to actually link this back to that Isern Kebschel slide back there. It's very much now about upping the activation of all available muscle units to reduce degeneration of those muscle cell of the myofibrils. We can do this by utilizing the aponeurosis properties that we talked about earlier. So that is, if we put it in a range and do contractions in here, that we're pretty safe. We've actually shortened the aponeurosis, and so we can use that plus or minus the adhesions of the surrounding muscles, and we can go to town on things such as prone and TheraBand holds, and athletes can get pretty sick of these because we can do multiple daily sessions, multiple reps, and just keeping an eye on any changes in symptoms. But by and large, these are pretty benign sort of exercises. Stage 2, where we want to start our some form of generalized movement. So I'm not quite going to call it strengthening, but certainly it's about matter of actually utilizing mechanotransduction, a bit of muscle pumping and others to help this healing connective tissue. So we'll often start off by splinting alongside it, either with the muscles, with the rest of the hamstring group, and or double leg approaches, bias this more to single leg later, and we'll do this for a longer period of time than you'll tend to with the myotendinous units. So how would we do this? It would be more about mid-intensity concentric eccentric sets through small ranges, just not outer range. We could add pulses in that as well, and or pulses at different points in the range. This is Scott Epsley's suggestion. who also suggested that blood flow restriction could be something that we could consider here. And blood flow restriction has actually been shown to increase M2 activity, something else we could consider. Do be aware that sustained isometrics, particularly at length, may attenuate the scar. That is, we end up with a longer aponeurosis, which certainly may increase your slack length and change the actual overall biomechanics of the myotendinous unit, which is not a desired outcome. So I'd probably caution against that. Again, multiple sessions a day, as we would for the calf. Then we start to get into pretty standard sort of hamstring rehab. So I just want to point out some of the degrees of difference rather than anything else. We're integrating the affected muscle, looking at particular deficits, formal strength sessions 3 times a week, 3 sort of exercises, 3 sets to failure, however you might do it. The thing, again, still about this limited load and range early, but one of the things you can really push at people here is the work of Stu Phillips, where we can do just multiple reps to failure, which might be 50 and 60 reps to failure. You can induce lactate in the muscle, but again, we can do this in limited range and with limited load of 30 and 40% MVC. And I think this is something that's really useful in the rehabilitation of these. But later in this phase, we can obviously start taking out their length as well. Same time, we want to address any specific deficits and which might be specific to deficits in long-headed biceps activation, medial collar inhibition, or dominance. And a lot of these features will be much more about your following weekend than it should be about this particular presentation. Similarly, and Ender, what better person than be talking about the kinetic chain, the synergists, and other muscles as well. So, but of course, arthrogenic inhibition becomes relevant to us and something else to be considered as well. So the other point I want to make, as it particularly relates to this connective tissue, is some form of supplementary mechanotransduction focus on the particular region. So rather than just doing whole muscle sort of work and graduating from there to running, I really like to see an increased focus on the muscle, either with eccentrics or medium intensity quasi-isometric holds. I'll show you some of that. You might also look at any outer range deficits about this time. I didn't know where else to put this. You'd be well acquainted with the work of Bolshaw and others, Rehorn and Sylvia Blemke, similar sort of work where we find that athletes with this reduced aponeurosis area either contributes to an increased risk of hamstring injuries or recurrences. So that obviously, as well as getting back our aponeurosis, as well as normalizing or in fact improving upon our biceps long head volume, that we do need to consider the aponeurosis as well. So there've been various studies on this. Certainly Matt Bourne in his earlier work looked at improving biceps long head upon muscle bulk, but I don't think he looked at aponeurosis there. But I know they've got a later paper where I thought they showed an increase in aponeurosis cross-sectional area, but I could not find it. Whereas Mayo, in this very recent paper, they used quite a different position. Rather than Nordics at length, they used this sort of hyperflexed hip eccentric loading, which is something similar that I've seen Inda King do in a pulley setup. But and of course they found both an increase in muscle volume as well as aponeurosis area. in this area, whereas Steph Lazarchuk in her recent paper with Ryan Timmins and Matt Bourne, they did a 10-week intervention as opposed to a 12-week intervention here. They found hypertrophy of biceps, but no change in the aponeurosis, which is problematic as it may well load up the aponeurosis more. I'm pretty much just going to finish with a pondering here of, so a lot of these interventions have looked very much at eccentrics, looking at targeting the hamstring group or the biceps in particular, and you can get biceps more by externally rotating. But if we consider the loading in late swing phase, we know we've got loading intensities, tensile loads of 8 or 9 body weights a second at 9 meters a second. But this occurs in about a very small, in about a tenth of this overall loading cycle. So it's about 40 or 50 milliseconds. So that the actual peak loading rate is about 162 body weights a second. That's quite different to sort of slow paid out eccentrics. And I do think we need to consider this. But the other thing is that these are very high tensile loads. And again, a great review very recently of what we might expect in terms of peak tensile loads, either of torques across the knee or torques across the hip. In late swing phase, of course, over 50% of this comes from semimembranosus, about 30% from biceps, and then short head, and then semi-T. So the thing is, should we consider stimuli that are more similar to that the hamstring is actually seeing in biceps in particular, with its greater payout of length in this late swing phase? But these are very brief loads of very high rate of loading. So things like perturbations of very high intensity in bridge catches, or can you do perturbations of hip extension? And so we played around with a couple of different versions here. The first one being of tantrums. You would love to have this ideally at optimum length, so a little more hip flexion. But with external rotation here, we got with neutral, very good firing of semimembranosus, external rotation, very good firing of biceps femoris. We can then do in 45-degree hip flexion. This is bilateral, but of course you can then bias it across to the affected leg and shake away there with external rotation. Again, this got more proximal biceps as opposed to more mid biceps alternatively. And then a similar thing here with, again, shaking the weight. This was 10 kilo weight, much more effective than a 5 kilo weight. Last up, just, we would go through running progressions, the same running progressions that you'll talk about next weekend. It's a unique stimulus, you know that. My concern is that from the eccentric type loading to then get to this high speed running, and of course we're progressing running to get there, but are there other things we can do to super protect our injured biceps? And of course then at the end, there are people survivors. They go back. How do they survive? Is it altered biomechanics? Do they have lower max speeds or whatever? But we do know that they're less resilient to changes in load, changes in surface, change in training transitions. So we need to stay on top of all the things that I've got there. So with that, I'd like to close, thank a whole host of people, and too many people who are not here, but of course, again, a lot of people have contributed to this and to my learning. So with that, I'd like to hand back to our chair in Paul Dykstra.